So we will be starting very soon, just giving a few moments for more participants to join us. So with that said, good afternoon, and it is a pleasure to have you with us here today. Before we begin, I would like to acknowledge the traditional custodians of the lands on which we work and live. I pay my respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples. As a language professional, I recognize that Aboriginal and Torres Strait Islander peoples are the original communicators and storytellers of this land. I honor the enduring strength and diversity of First Nations languages, the First Nations of this continent. Also their role in maintaining culture, identity, and connection across generations. My name is Despina Manatidu, and I am a language professional and NATI certified interpreter and translator, and the head of interpreting of 2M Language Services. It is my privilege to lead the delivery of the Interpreter Employment Success Program, which is an Ethnic Communities Council of Queensland initiative delivered in partnership with us, with 2M Language Services, and also Settlement Services International. The program is funded through the Workforce Connect Fund, powered by the Queensland Government's Good People, Good Jobs, Queensland Workforce Strategy 2022 to 2032. So before we begin today, I'm going to go over some brief housekeeping rules. You're encouraged, as always, to submit questions and comments using the chat function or the Q&A box of your Zoom. AI note-taking tools or external recording applications are not permitted, so they will be removed if they're featured in the participants. As per usual, we have Auslan interpretation to support accessibility for all attendees. So we kindly ask speakers and participants to be mindful of the Auslan interpreter by speaking clearly and at a measured pace to ensure accurate and effective interpretation. And I have to remind myself of this each and every time as well. Lastly, we won't be issuing any certificates for this webinar, but should you be audited by NATI, we are more than happy to attest to your participation to this session. And now, with all this covered, welcome to the IESP Induction Webinar number 6, Interpreting Mental Health Conversations, Skill, Ethics, and Readiness. We are delighted to have with us today our presenter, Dr. Jim Clavage. He has been a practicing NATI certified interpreter and translator for nearly 30 years. He has been a translator and interpreter trainer at postgraduate level and professional development instructor for over 15 years. Jim has also worked extensively in the area of mental health, authored the Mental Health Interpreting Guidelines for Interpreters in 2017, and was part of the research team that developed the Mindset Training Program, which we examined at length during the last webinar. And it is for interpreters to work in cognitive assessments. Jim is an adjunct senior research fellow at Monash University in Victoria and has published widely in the field of translation and interpreting studies. Jim, thank you very much. Over to you.
Thank you very much, Despina, for this very kind introduction. Thank you also to 2M, and thank you all of those people attending this afternoon as part of the Interpreter Employment Success Program. And this is a presentation on mental health interpreting. We'll be covering quite a bit of material this evening, so without further ado, let's commence with the presentation. So, mental health interpreting matters. And why does it matter? It's now a very common area of work for a lot of interpreters. And this is partly due to an aging society where cognitive related conditions are now becoming more common. And there are also higher rates of self-reporting that people might have a particular mental health issue. Mental health is a sensitive area, and when people are talking about their health, they can sometimes feel various feelings such as shame, sorrow, grief, etc. And when you think about when you feel these types of emotions, when you express yourself, you might not be as fluent or as coherent as you normally are. And so a person who is accessing mental health services may be communicating, may be speaking or signing in a less than coherent way. And it's important for you as an interpreter to know that the patient that you're working with trusts you, and also that the practitioner that you're working with trusts you. So we'll be covering these basic things and a lot more in this presentation. So where do interpreters work, and with whom do they work in mental health settings? On the left-hand side, you can see the settings. There can often be ones where mental health interpreting takes place. And this is important if you go to the boards or receive messages or invitations for an interpreting assignment. If there are details about the venue, and the venue is any of these things on the left, this indicates to you that this is likely to be a mental health interaction. Sometimes there's also further information about the person, the professional that you're working with. On the right-hand side, you can see occupational therapist, social worker, and so forth. These are professionals who often work in mental health services. And so if you see any of these occupational titles, that's also an indicator to you that it's likely to be a mental health interaction. And this is all part of your preparation to know where you're going and with whom you're working. Now, one of the settings that I showed you in the previous slide was working with CAT teams. CAT teams refers to crisis assistant teams. And crisis assistant teams work with people who have mental health issues. They might be psychotic. They might be quite excitable, and so much so that they're perhaps a danger to themselves or to others. And when this happens, a person in the public or a GP or a police member might actually then contact CAT team to see if they can help the person who is exhibiting particular disturbing forms of behavior. Now, as an interpreter, you're likely to be working on the telephone if you're working with a CAT team. And what the CAT team does is what's called triage. Triage is a process which elicits key information, what's happening. Firstly, what's happening to the individual. So a CAT team member might ask, okay, whereabouts are you? What's happening? To try and find that basic information. Then they might ask, is there anything in your hand? What's surrounding you? To work out if there are things that that person has which could be dangerous to themselves or to others. And so they'll ask questions to answer these questions, to get answers to these questions that you can see on the diagram here, the triage diagram. Now, this principle of triage is something that a lot of mental health professionals use, not just CAT team members, but psychologists, uh, psychiatrists, mental health counselors, etc. Basic information at the first instance to know what's happening, are there dangers, what do I need to know? The triage is something that is important to note. It's a key strategy that lots of mental health professionals use. Now, in that first slide that I showed to you, I talked about mental health and often people feeling sorrow, shame, pain. And as I said, when people are feeling these things, their speech or their signing can be incoherent or confused. It might not be very cohesive or linear. In the case of people who have had a stroke, they might be slurred in their speech. They might have lots of hesitation markers like ah. They might repeat themselves and so forth. Some people with mental health conditions have physical symptoms as well. They might not be they might not be following normal or expected standards of personal hygiene. At a home visit, this means that it can be a bit different from what you otherwise expect. And these are symptoms often of some mental health conditions. And sometimes they can be quite conspicuous in the way that they talk or sign. They could talk about themselves in the third person. They might use a lot of coarse language, etc. And so this is a bit different from physical health interactions. What's also different is that instead of physical health, where you have, let's say, a broken leg and you've got an X-ray, you can see a fracture, and the orthopedic surgeon can treat it. With mental health conditions, often it's language, a person's speech or their signing that is the only symptom of what's happening with them, of their mental health condition. So what this means is that the work of the interpreter is even more important because they're the sole person to convey the symptom and for the clinician to then diagnose and then to provide treatments. So how do you best prepare for mental health settings? Well, I talked before about looking at what is the venue of the assignment. And if it's a neuropsychology department, then hey, it's going to be a mental health one. Look up what happens in a neuropsychological test or neuropsychological assessment. Then when you actually get to the interaction, it is important to request a briefing. So before you start interpreting between the clinician and the patient, ask for some private time with the clinician to receive a briefing. If they don't offer it to you, ask for it. And just say, excuse me, if you don't mind, can I have 3 minutes of your time just to ask you some basic questions about how we're going to work with the patient. Now, in that briefing, you could commence the briefing by introducing yourself and your role, asking them if they worked with interpreters before, the overall purpose of the interaction, are they working with the patient for the first time, and other things, which you can see here on the slide. And I'll show you in a moment an actual model of a briefing, a script that you can actually deliver that covers most of these things. I won't read these scripts entirely. This will be part of the notes that are going to be made available to you by Despina and 2M. This is just an example of what you can say to the clinician for the first time to start the briefing off, and they'll respond to your questions in turn. Now, the last sentence here says, if we're ready, I suggest you speak first, you're the clinician, you're commencing and leading the interaction. I interpret what you say, and then I will introduce myself. So I'm going to show you a model script for what you could then say to the patient to introduce yourself. If you introduce yourself, your name and your language combination, have you worked with interpreters before, and other things which I've listed here. I've put in bold something quite important, and that thing is to say to the patient, everything that you say will remain private and confidential, and I will not pass any information on to others. I mentioned before that mental health is often associated with shame, pain, guilt. It's really important that the patient is comfortable and trusts you and knows that everything that they say or sign and you interpret will stay with you and you only, that you will respect their privacy and that you will not pass anything on to anyone else. It's important that you convey that yourself as the interpreter to the patient. And there are other things you can say, but also allow them to ask if they have any questions. They might want to ask you something before the interaction commences. Sometimes in mental health interactions, you're also working with family members, or they're there, they're present. And it's important that you introduce yourself to them if they're part of the interaction. And this is an example of a script of what you can say to them. They might be English speaking, they might be Lloyd speaking, whatever. Sometimes they might feel that they need to or should interpret for their family member rather than you. This explanation to family members clarifies what your role is and what their role is. And typically what it is to offer support for the patient, sometimes also to share information as well. So these are three scripts to keep in mind when you request your briefing, when you introduce yourself to the patient, and then to the family members of the patient if they're present. So let's say the interaction has just started. What things do you need to keep in mind? What you need to keep in mind is that you interpret everything and only what the clinician says. So if a clinician asks a question just once, then you interpret that question just once. If the patient uses derogatory or vulgar language, you interpret that as such. It's important that the clinician hears and knows what they're saying for them to know what's happening with the patient, and this can help with their diagnosis or for them to know how effective the treatment is. Try not to paraphrase, except if there's no equivalent term, let's say in the LOT. And often the term respite in English is something which is not common in the LOTs that I work in, and I often have to explain what this term is. But this is a specific term, and try and avoid it unless it's necessary. Similarly, with cultural information, there are lots of differences between ways people speak, etc. Only if it's important to the interaction itself should it be discussed. And sometimes you can perhaps keep that information for a debriefing. I mentioned the importance of the briefing. At the end of the briefing, also perhaps ask, could we also have a debriefing at the end of this, if possible? And that's perhaps the opportunity to go over things like this if you can't convey it during the interaction. Some other logistic things are, if possible, don't have contact with the patient before the interaction. That helps to maintain your impartiality. And as I said before, if it's a home visit, expect the unexpected. but don't laugh and be judgmental. That's part of your role as a professional, to be there and to work with the clinician. So during the interaction, you might have the patient expressing themselves quite unclearly. If it's unclear, don't make it clearer. Try and replicate the same level of lack of clarity in your interpreting. So don't make sense when there is no sense. Don't paraphrase, as I said. Don't provide extra cues. As I said, if the clinician asks a question once, you just ask it once. Don't prompt them. Don't add extra hand gestures unless the clinician uses them. And try not to say, well, I can't understand this, but I think what they're saying is this. Try and replicate exactly the level of coherence or lack of coherence that the patient has. And don't do some other things. Don't answer on behalf of the patient, obviously. Don't provide feedback or encouragement unless the clinician provides it. Sometimes there's a reason why the clinician doesn't provide feedback. Don't praise them, etc., and so forth. But if the clinician has a good bedside manner, you also need to display a good bedside manner. That's part of the empathy and care that mental health professionals show towards their patients. That's also part of your interpretation. If it's there in how the clinician addresses the patient, it needs to be there in your interpretation of what they've said. Now, all of these things are challenging, really challenging. You can see this further list of things that are quite hard to convey. They're not easy. I'm not pretending that they're easy. How do you convey these things, these challenges? Well, let me just give an example of an experienced um, mental health interpreter, a colleague of mine, who was describing one interaction that was memorable to her. I'll just pause for a moment for you to read how she describes one interaction. Okay, so how to interpret speech or signing that's very incoherent. There are two plans you can follow. Plan A is, if you can, fully convey the content and the form of the speech into the other language, into English. So if you can replicate the level of incoherence, blurring, hesitation phenomenon, stop, start, whatever it is, in your interpretation, so that the clinician hears exactly how the patient spoke or signed, then that's fantastic. I have to say that I'm rarely able to do this because it's very rare that I can really convey it in exactly the same way in the languages that I work. And I suspect that will be like that for you as well. So if you can't do this, and it's hard to do, then your plan B is the following. If you can't fully convey both the content and the form, what you need to do is to convey to the clinician the content. Let's say, last night I was dreaming about green peppers. And when I woke up, I thought, this is a really bad thing that's going to happen to me. And things like that went bad for that whole day. Let's say that's an example of what the patient said. I haven't described the form, the way that they said that. And if the patient was very animated or they switched between English and the other language, I need to convey that to the clinician because this is important for their diagnosis to know how the patient is speaking. I then add things about the form, the way. the patient said that. So they were very animated. They had slurred speech. The patient used the third person referring to themselves. There was profane or coarse language. This extra information is important for, as I said, the clinician to know how the person is expressing themselves. Okay, I'm going to now just briefly stop sharing the presentation, and I'm going to pull up a short video which goes for 2 minutes to show you the an example of a to show you an example of a patient who has psychosis, and they're working with an interpreter and a clinician. So I'm just sharing this now, and I'll just commence this now. I hope you can hear the audio.
One of the most difficult situations interpreters encounter is when a...
Sorry, can I just check, is the audio coming through to you?
Yes, it does.
Okay, thank you, Despina.
patient's thinking or language is seriously disturbed by their mental illness. This can happen when the illness affects certain brain functions. It's an event that is commonly seen in the emergency room, in inpatient settings, and occasionally in outpatient settings. But unless they work in the mental health field, most people have never seen this kind of thinking and language disturbance. It takes special skills to interpret for this type of patient in a way that is helpful to clinicians. This vignette has two parts. In the first part, the Spanish language interpreter is startled and confused by the patient's disturbed thinking and communication. Although her difficulty in translating the patient's speech is understandable, the interpreter reacts in a way that is not helpful to the clinician.
So I'm just pausing for Donna. Donna, you okay to continue? Okay, we'll continue.
I'm crazy, I don't know why I'm here. Oh my. This is very difficult. Jesucristo era un revolucionario, It's very comunista, era comunista. She's talking about everything. Lo mataron porque él. I'm sorry, I don't think I can translate this. Y yo quiero competir y no me quieren. No.
I'll just pause for Donna. And we'll continue.
While the situation in that last scene certainly presented a challenge to the interpreter, she was unable to find a way to be helpful. The clinician was aware that the patient was speaking a great deal, but heard almost no translation. He was left with very little information about the patient's disturbed ideas and language, and he could not do his job. But when a patient's language and thinking is so disturbed, how do you interpret that? It isn't easy. Watch again. In this next scene, the interpreter uses a more flexible interpreting approach that works much better.
I'm not crazy. The computer is alive. Her language is very unusual. It's difficult to translate. Let me describe it for you.
Please.
She's talking about the computer. It's got arms. Something about the trees. She's talking about swimming with fish, but the word that she uses for fish is prepared fish. Her speech is very rapid. She's not really logical. It's kind of hard to follow.
Okay, that was an example of an interpreter in the second instance, conveying the content firstly, and then giving a description of the form of the patient's speech. Here is some further examples from experienced interpreters who have actually relayed to me what they said to a clinician about the form of a patient's speech. They just conveyed the content, and this is the way that they conveyed the form, how the person spoke. So these are examples of how you might convey how the person has spoken if they've displayed these characteristics. Okay, we're moving on to another topic. That is if a person talks about harming themselves, or perhaps even expressing suicidal thoughts or harming others. And so sometimes you might hear a patient saying to you, "Oh, no one helped me. What do I need to do? Jump out a window?" Or other comments which indicate that something harmful could happen to them or to someone else. Now, if you hear this and you're with the clinician is equipped to know how to deal with this type of language. If a person expresses a desire to hurt themselves, the clinician is there and knows how to deal with that. However, you might find yourself in a situation when you're alone with the patient. We recommend you try and avoid this for this reason, but it can happen that you are the only person there with the patient and you hear them say something like this. What do? Well, these types of comments are life-threatening. And when you hear a patient saying something that indicates harm to themselves or others, you need to convey this to someone else. You need to break confidentiality because it is more important that you convey this possible danger to another person than to observe confidentiality. And the most appropriate person that you convey this to is the mental health clinician that you're working with, or that if they're in the next room or what have you. So if you do hear or someone signs in this way, please report it to someone appropriate. You are not bound by confidentiality in these situations. And so for this reason, we try and recommend to not have contact with the patient beforehand for these reasons. And also sometimes the clinician doesn't want the patient to bond, as they say, too much with the interpreter. They're looking for the relationship with the patient to be an equal one, where the clinician is just as close to the interpreter as to the patient as the interpreter. And sometimes spending time with them can blur the boundaries. And I'll talk a little bit about role boundaries in a moment. Sometimes in the course of an interaction, they can address you, the interpreter, as if you're a doctor, as if you're the clinician. When this happens, repeat to them that you're the interpreter and you're working with a clinician, and the clinician is the person here, but I'm the interpreter interpreting what they say. And please back translate that to the clinician so that they know what you've had to say to the patient. So you're just re-clarifying your role to the patient when that happens. Some patients that I've worked with, though, don't take this in. And so when it is an ongoing problem, what I do then is I switch to third person. Now, third person interpreting is something we do not recommend. It's not good practice. But in this instance, to make clear to the patient that I'm not the clinician and that the clinician is someone else, I switch to third person. And so I say, the doctor said that you could, etc., to make it clear to the patient that I'm repeating the doctor's words, not speaking to them myself as a doctor. Okay, the nature of mental health interpreting is that it can be stressful. You can encounter a lot of people who are in distress. That's often not easy to witness and to work with. And I know quite a few interpreters who work a lot with survivors of torture or people who have lived through horrible experiences, that this can be a recurrent and common thing. Even though you haven't experienced this, when you hear about this or see it often and often, you can develop what's called secondary traumatic stress. And some of the symptoms of this are things like what's called intrusion or avoidance or hyperarousal. And there's some definitions of what these terms refer to here on this slide. So these are symptoms that your work is starting to affect you, your personality, and your well-being. Now, when things start to become stressful, you know, we have ways to kind of unwind, to kind of take a break from work, and it might be whatever, physical exercise, going for a walk, listening to music, what have you. And these can help if it's only a minor issue. You have a hard day and you go for a walk and you feel better, whatever. However, when it's a deeper problem, these strategies won't be enough. I know some interpreters who've worked a lot in this area and they can develop themselves an issue, a problem. It can even lead to burnout or vicarious trauma. There is information about self-care from Metro South Health in Queensland. I'll make sure that this information brochure is part of the resources made available to you. There are some suggestions and recommendations for you to deal with challenging situations, to follow self-care. However, if it's more serious, you can also see a counselor. I think 2M, I'm pretty sure 2M, but also most other language services providers are part of the what's called Employee Assistance Program. And in fact, any NAATI certified interpreter is eligible to have EAP. What it is it's free counseling. It's anonymous, it's confidential. And in the case of NAATI, the provider of the counseling is an organization you can see on the right-hand side. It's TELUS Health. But I'll be speaking to Despina to make sure that you receive information which is appropriate to you for EAP, your provider in Queensland. So this is also available. It's free, confidential for interpreters who request it. So rounding up what we've talked about this afternoon, what are the key takeaways that you can take from this presentation? So firstly, prior preparation, knowing where you're going, with whom you're working, looking at terminology. I'll share some resources in a moment. Watching model videos, you can practice mental health interpreting, and reading info sheets, both in English and in LOTE. Secondly, learn about mental health services. What does ACAT stand for? That's the Aged Care Assessment Team. That's the team of usually occupational therapists who go out and conduct a cognitive assessment of an older person. What's neuropsychology? What's CAT? Start to learn the terms, the acronyms. And if you can learn also about the professions that you're working with, mental health nurses, what do they do? Counselors, psychiatrists. Please also follow up any PD opportunities. And AusID has some, and in a moment, I'll show you one next week on mental health. And when the opportunity arises, speak to other colleagues. It's really important. We don't always get the opportunity, but when you do meet up with other interpreters, talk about mental health interpreting because it is a challenging area. And lastly, reflect on your own performance after an assignment. What did you do well? Not so well. Did you enable others to do what they needed to do in that interaction? So as I said, this is happening next week, Wednesday, the 8th of April. And I'll make sure that through Despina and Mariola that you receive this information in your resource section. So yeah, it's free, by the way, to all AusID members and NAATI credentialed practitioners. 2 hours next week. So if we had to produce a checklist of the things that you should keep in mind about for you to know, am I ready to take up a mental health interpreting assignment? Do you know how to prepare yourself before the assignment, to know about venues, settings, and different types of clinicians? Have you consulted videos, looked at info sheets? Have you got your script or your preparation at the start of the interaction ready? Do you know how to introduce yourself? Do you know how to request a briefing? What types of questions to ask in that? How to self-introduce yourself to the loudspeaker and your role? Next, knowing that you need to convey both the content, what the person says or signs, and the way that they say it. Don't be afraid, like in any other interpreting assignment, to request repetition or clarification. Ask for a debriefing from the clinician and think about resources that would help you to be an even better interpreter in these interactions. So I'm going to share with you some supplementary materials which I think have been made available to you already. Firstly, the Queensland Mental Health Review Tribunal. That's the internet address in the top left corner. If you go to their website and you go to the menu for patients, families, and supporters, you can see short videos which explain to lay people in simple language how the tribunal works, how to prepare for a hearing. And this is really good for you as an interpreter, for you to know what to expect. When I've interpreted at the Mental Health Review Tribunal, it's usually been for people who have received what's called a compulsory treatment order. That means that they have to follow a form of treatment by law for a period of, let's say, 6 months. At the end of the 6-month period, they come to the tribunal. The tribunal consists of 3 people: a medical person, a legal person, and a lay person. And they assess how the patient has been going. They hear from family members or a social worker, and they make an assessment. Does the person need to continue the compulsory treatment order or not, or perhaps something else? But on the right-hand side, you can see the different types of themes or issues that the tribunal deals with. There are other resources in particular for people who need to go through what's called a cognitive assessment. The most common tool is the Readiness test, but there's other ones here as well. They're listed here below. And what most of these tests have in common is that they want to elicit following things. They want to elicit how well the person can use their cognitive skills like conceptual reasoning. How would they cross a road safely, etc. The clinicians are looking at their verbal and signing skills, how articulate, how short or long their sentences are. There's also some number and math, and there's also physical movement following physical exercises or physical procedures that the patient needs to follow. And examples of the Readiness test in English and Italian and Chinese, I think, have been placed in the resources area for you to have access to. And this is just the start of the Readiness test, just for you to see what it looks like. It usually takes about 30 minutes to administer. If your interaction is a neuropsychology one, that can be a lot longer, and that can be like 1.5, 2 hours. So if you are, when you speak to the clinician during the briefing, do feel free to ask them, are you using any tools, any diagnostic tools? And if they are, ask them for you to be able to see them. They'll usually have them in paper form in front of you, and they should be happy to share this information with you so you can prepare for the delivery of that tool. I mentioned before you can do practice by following videos. There are lots of learning videos actually developed for psychiatry and psychology students, and this is an example. This is the YouTube site, the address. This is a simulated interview between a psychiatrist and a patient. The patient has been having psychotic issues, and what you can do is to play the video, pause at the end of each turn, and then produce your interpretation into LOTE or Auslan to practice actual typical turns, questions, etc., that a clinician will ask. And then you press play, you hear what the patient says, you press pause, and you interpret the patient's response. You know, there are quite a few. If you copy this address into YouTube, there are other things that will appear in the menu for you to practice on. There's also lots of translations that have been prepared by NAATI certified translators, and they're available in the largest health translation directory in the world. 130 languages, 39,000 resources. So if you go to this site, it's based in Victoria, but there are translations from all over Australia, including Queensland. You can type in as a keyword here, I've put in mental health. You can then go to language select your language, and then press the search resources. And you can see which resources are available in your language. When you click this, you'll come say let's say to let's say bipolar disorder. There will be a master text in English, and then the translation into your language. These translations are basically information sheets. And the good thing for interpreters is that they really closely replicate exactly how mental health interpreters, clinicians speak. You know, the words, the phrases, the diagnoses that you will hear from a clinician are often given in these information sheets. So do make use of them. Lastly, in Queensland, there have been some fantastic glossary resources developed. These are also available in the resources section. Even if your languages are not represented here, these resources have a big definition glossary at the start in English. So the term acculturation problem is defined, what it refers to. The most recent resource, which is more recent, actually has a very large number of languages. I think it's up to about 30 or 40. Again, this is produced by the Queensland government, so please do make use of it. It's a fantastic resource for you to have access to. Okay, that concludes this presentation. Thank you so much for your attention, and I'm happy to field questions or comments from the audience.
Great, thank you so much, Jim. That was definitely a lot of information. And if any one of the participants that are not practicing interpreters thought that interpreting or mental health interpreting, as for that, is an easy task, by now we have all understood that it definitely isn't. However, it is a type of interpreting for which we can be prepared because there is a plethora of resources and also training courses, webinars like this today and your upcoming webinar with the Professional Association next week as well as other resources. However, it's interesting to see that from the practicing interpreters in the audience, there are stories, obviously, stories of interpreting in mental health settings. The first one is really, really traumatic because for Renato, it was the first on-site interpreting assignment ever, and that took place at a psychiatric ward for a patient who had suffered from a psychotic manic breakdown. Renato, the interpreter, was not aware of this since the LSP did not even warn him or provided a proper briefing. So how was that for a career start?
That's a very tough assignment to receive as your first one. I don't know if Renato knew to ask for the briefing. The briefing is really, really important to know what you're going to be facing. You know, that script that I supplied to you, practice it. It enables you to touch lots of bases with the clinician, and to ask for example, sometimes there's a safety issue. Don't be afraid to ask this question. If there is a safety issue, then you might want to say to the clinician, I'm going to use a word like flag. If I say the word flag, that means I'm not feeling safe and we need to take a pause or a break. So that's not obvious to the patient, but it is something that the clinician will understand. But yeah, that's a really tough assignment to receive as your first one, Renato. I do sympathize with you.
However, Renato kept working with the clinician, the registrar, the family members, and obviously the patient, and the outcome was a lot better than the start. But proper briefing is obviously the responsibility of the language service provider, like 2M Language Services. However, I have to mention that the briefing we get for assignments, it's consists of very few words or sentences, and everything we get, we do pass it on. But obviously, the LSP, whoever commissioned that job, they would have to know surely that it was a mental health assignment, and they would have to know that it was your first assignment. So they should do better than setting you up for failure, which thankfully didn't happen. Then we have another story from Amanda where there was denial when it came to the mental health issue by the patient and by the overseas family. And of course, as we know, Jim, the interpreter is in the middle of all that and between the clinician and the other parties. And we have to navigate that not only successfully, but ethically. What do you suggest in this case where culture becomes a natural barrier?
In the first place, if a person is in denial or refuses treatment or a diagnosis, or even to participate in, then you follow the lead from the clinicians. Clinicians are trained to deal with all sorts of people who are reluctant, defensive, in denial, what have you. It's up to them to display their skills to deal with the situation. It's not up to you to deal with that. You follow their lead. And if they, in fact, abandon the interaction, then that's their call. If there are things such as, let's say, non-verbal messages that a person is conveying, which are not obvious to the English speaker, then that's meaningful. And they need to know about this being conveyed. So there could be, for example, the way that the person does not share eye contact with the clinician, the way that the person uses their hands in a perhaps dismissive or defensive way, which is not obvious to the English speaker. I mean, many times these signals are obvious or they're common, but if they're specific to the Lote language and you recognize them as such, you need to convey this to the clinician so that they know, that person actually conveyed a signal which is showing their disapproval or reluctance or disagreement with what you just said. So that the clinician then knows, okay, my next sentence, how do I address this disagreement, this disapproval? Again, they're the skilled clinician, right? It's within their skill set to deal with difficult, disagreeable patients. Again, a debriefing is really important at the end, so that if you can't actually, sometimes cultural issues are really big, and you think, if I want to actually convey this, I will have to actually ask for a pause, and it's not practical to pause an interaction. So you need to keep that in your memory, ask for a debriefing, and convey to the clinician, okay, one thing that I couldn't convey to you 5 minutes into the interaction was that the patient was this or that or what have you. So that knowledge is then still conveyed to the clinician so that they know about something that happened, right? So you need to use some judgment. I know it's hard for newbies, and a lot of you are newbies. You kind of need to have a feeling. You can ask the clinician, something has happened. Can we actually talk about it, or would you want to continue and we can talk about it afterwards? Don't feel free to ask the clinician if something happens, how you want them to proceed, because they're the one leading the assessment, the assignment. You know, it's not up to you. Can actually free yourself from the responsibility by saying, look, you know, whatever their name is, something has happened. Can we talk about it now if possible, or would you prefer we talk about it afterwards? Feel free to ask the clinician this question.
Thank you, Jim. And obviously, a lot of the practicing interpreters in the audience there, we have interpreted for the Readiness test for a number of patients. So we are very familiar with it. However, that's not to say that it cannot be tricky each and every time, because it is affected by so many different parameters, language being one, if it is affected as well, but many others as well in terms of cognition. So although we have the test, we are familiar with it, it doesn't mean that it is an easy rendering back and forth. But other than that, there is there's only praise that I can see in the chat for obviously the presentation and the content. Thank you so much, Jim, for the Auslan interpretation and for the ISP that has put it together. There is also a short survey which you're very welcome to complete. So you let us know anything more in detail in terms of feedback. But also the resources that Jim has been mentioning throughout the session have already been made available on the website. The only thing missing is the slides, the PowerPoint of this presentation, which will also be made available. So I encourage you to go onto the website and have a good look at the resources if you haven't done it already. And after that, as we heard, there is also another webinar coming next week and many other resources if you are interested to delve deeper into mental health interpreting.
Thank you so much, Despina. Thank you, Donna, for your Auslan interpreting. Thank you so much. Thank you, Despina, again, to 2M, to Mariola for your organisation. Thank you also to the Queensland Interpreter Employment Success Program. And thank you again to all of you for your time and attendance at this presentation. I hope it's been used to you, and I encourage you to pursue further mental health interpreting PD, and all the best in your future practice.
Thank you so much, Jim. And with that, we will leave you to have a lovely rest of your day, and we will see you next time. Thank you for being with us tonight. Thank you again. Bye. Bye.